as a coach, I feel these are some takeaways that I think contribute to the success at Community Health Services. And number one is having strong leadership support. And you'll hear from Shera in a minute. And that made all the difference in the world. She was totally behind this transformation and supported her staff and the practice and the 5 practices that I worked with in this journey. So that is number one key. And then next is developing a QI team, a quality improvement team. That would be people from all over the practice. And at some of Community Health Services practices, they're run by one NP and one MA. That was their quality improvement team. So I've seen large quality improvement teams and very small quality improvement teams, and they all work. Having regular meetings, so we met together twice a month. When a month goes by, it's very hard to keep the progress going and to develop those best practices. The other thing is everyone in your practice has a role in the transformation process. So I always say MAs are the eyes and ears of the practice. They come up with some of the best practice development of anyone in your practice. So really utilize everybody in your practice for transformation and change. And I think that's what Shera was so open to, is that, yes, she's the leader, she's the MD, but everybody can have a voice in this work. This particular practice focused initially on one chronic condition, which was asthma, and I think it helped them set up the journey to be successful. So we did processes and workflow. We met regularly to tweak these processes. They began looking at the registry of asthmatics. They had never had a registry before, never collected data. So this was back in 2010, and at the end of 2010. And so they were able to really get into their data and transform a lot of the work they did because of their data and seeing where opportunities were. Then the next thing they did that I feel is essential, and I know that this is going on at a lot of practices, is outreaching to your patients. So getting these high-risk patients in, getting patients in for focus visits, opportunities that you have to get them back into the system and seen on a regular basis to keep them out of the ED and hospital. And then we had a learning community where they shared best practices. Just what we are doing today, HealthTeamWorks holds regular learning collaboratives, but I think this is a great opportunity for people to share and have takeaways that may work in your practice. And I guess the final takeaway is that quality improvement never ends. It's a continuous process. It needs to be at the center and forefront of the work you do. You can't let time get away from you. Things just kind of fall apart unless you're really nurturing the processes and making sure that that they're sustained in the practice. And having great leadership, so I'll hand it over to you.
So, like probably many of you, we're an extremely overextended organization. And so we kind of went into this, I said, what are the chronic conditions that children face? Asthma and obesity, and I said we want to do the best that we possibly can in taking care of these children. And I think as a leader, it's really important to acknowledge when you're doing well and leave it alone, because there are so many opportunities for change and for initiatives and for getting involved in different things, and it's really easy to get change fatigue and to just overwhelm your staff. And so we really went into this saying, all right, how do we take care of asthma? And my provider said, we do a great job. And I said, okay, let's see. And so that's how we first brought data into our lives. And at first they were like, we don't have time for data, we're so busy. And so that was our first opportunity to say, okay, let's look at workflows. Let's look at who does what. What are people's job descriptions? What's the flow of your day? And we were able to fit in data. And when we fit in data, we really saw that our providers weren't taking care of our moderate and severe asthmatics very well, that we had really bad patient follow-up, and we had some issues with compliance. And we had a lot of patients that we hadn't seen in 3 or 4 years. And the provider said, you know what? That's because they're going somewhere else. There's so many other opportunities for people to go places. And so we said, okay, let's call them. And so we called up all those patients, and they weren't going anywhere. They were going to the emergency department. They were spending every year in the intensive care unit. And so we started bringing our patients back. And as we did that, that really helped us establish our relationship with our patients. And really, when we went in to become a patient-centered medical home, it was like an hour and a half visit, and we had it done, because that had been our journey for those years of really making these strong relationships with patients, calling them back, checking compliance, and so that's kind of been our journey. And now, as we're facing any new challenge or issue, my providers are right there ready to change things, alter things. For example, like asthma, we said we're not doing good with how we treat moderate and severe asthmatics. So we went to establish protocols, which everyone kind of pushed back at first. And then that created partnerships with other organizations for us. So National Jewish actually bought us a spirometer and taught us how to use it. And at first the provider said, we don't have time for this. This is crazy. This isn't going to help us. We can just refer patients out. And now the spirometer has been broken, and I think the world's going to end. And I get called about it all the time because they don't know how to get through their day without using it. And now all of our moderate and severe asthmatics we have the numbers to show that we're taking great care of them. To use spirometer to help him see what his asthma was really like, because he was a poor perceiver of how sick he was. We were able to work with the family and figure out he couldn't manage his medication on his own, so we got him down to 1 dose of medication at school with the school nurse, and he's now on a medium dose of 1 inhaler every day. And his asthma, he was in an intensive care unit this year for the first time since he was, 6 or 7. So I just, we've really become a culture of change because I could show our providers, I could show our staff that this makes a difference to our patients. Yeah. And we got to get a clinic manager, which is like revolutionary for us, and just to continue all the things that we wanted to do because we did run out of time. And Deborah's been with us, and we wouldn't have survived our now EMR transition without her. And she's just does an amazing thing. So.
Practice management director at Doctors Care. Been there a couple years, and it's a newly formed position, and pretty much pioneer of everything new that happened in the last 2 years. So the job evolved. As you probably know, Doctors Care is a safety net clinic, and we really strive for integrated care and to be a patient-centered home. We're not a doctor's office. We're a patient-centered home. We couldn't function without volunteers. At least 50% of our staff is volunteer, and I highly suggest to people in profit business, get volunteers, because you're never going to make the progress you're going to make with the staff you have, and there's people out there that want to help. So we have a huge belief in partnering with our patients, and in our eyes, we have a culture where the patient and the clinic are partners, not just the provider. And we believe as much in navigation as we do in medical care, which we've figured out kind of the hard way. They come arm in arm. They're not separate anymore. But so we created this culture, very similar to you all, of from front to back. How do we communicate and how do we message to patients that we're your home? Don't go to the ER. If you're scared, call us. We're here. We have digital signage. We have magnets. We purposely have nothing hanging on our walls. We don't want paper and posters and garbage. We want one message to them. And so we keep it very simple, very quiet. and the signage is the same signage is up front with the reception, same signage in all the exam rooms. And it's how to get a hold of us. We're here for you. And we identify these people. And I think it was Deb mentioned better coordination of services, but that's really the key to all of this. So navigating with your patient, you've got to identify and capture where you can on people. We don't find out people have been in the hospital. You're lucky if you find out. Sometimes by the time we find out, it's been a month, or they never tell us, and they keep going and going and going. So with this new SDAC, it's really helped to identify these people and go, holy cow, have you ever even known this patient was ours? And so with the help of volunteers and our staff, we identify these folks. We put alerts in so the front office sees it. Oh, gosh, you've been in the emergency room a few times. What's going on with you? Back office, MAs work their rears off and are usually multitasking, so we aren't that dependent on them to catch a lot. They catch a lot of medical things, but they're so busy that the whole navigation culture is hard for them to capture with that patient where they're doing vitals. So they're like third in line. If I've got a patient that we've identified thanks to SDAC that is a high-risk patient, I'll make a point to be up at that front desk with the front office staff and say, hey, I'm Shera. Gee, it looks like you've been struggling or whatever. We'll pull them back. We'll talk to them. So we have a volunteer, one of them, who's doing nothing right now but identifying our high users. And she's calling each one of them. And of course, the kind of patient we see is Medicaid or very, very indigent. They're transient, and we have a terrible time finding these people because they move constantly. But we literally have a volunteer doing nothing but finding these people, identifying what they've been in and out of the hospitals for, and trying to get them in. And again, saying, hey, did you know that Doctor's Care is your primary care provider? Most of them don't even know. So we introduce ourselves and tell them that we want to be their medical home. We want to be their partner. We really get them involved. The one I can think of right off the bat when we first learned the SDAC, and we are integrated care, so we do have behavioral health there. And I had identified a woman that was in her 20s, I'll leave it at that. She had been at the hospital 12 times and admitted over 7 times in less than a year. And they were all mental health, emergency complaints. I mean, she had stomach pains and this and that, and she had been admitted over and over and over with all these vague issues, but with behavioral health in the background. And we got a hold of her, made a 45-minute, hour-long appointment with her. I met with her. The providers met with her. And we have patient navigators that are volunteers followed up with her. Now she's like a different woman. We've got her meds checked. We got her on proper medication, because what happens is they leave the hospital on bizarre meds. No one follows up. They run out of their pills in 30 days and go right back to the way they were. So I encourage them to get organized, and we have people work with them. And the reason we do this, too, is the provider's there to provide medical care. The provider can only do so much patient navigation, and they're already trying EMR right now and trying to pretend they're going to get that patient out in 20 minutes. So anything that the staff can do to support that is helpful. And we've also said, hey, you've got to comply. You can't just do these things and not be held accountable. And we'll say, if you want to be a part of our family, you've got to comply. You've got to have consequences for your behavior. And so, although we don't dismiss, can't do that, we are very stern with them at times and have a few, come to Jesus discussions with them. The other thing that I'm very strongly involved in is getting involved in our community. We navigate with anybody and everybody we can think of. I visit every public school in my neighborhood. I visit pediatric practices that go, I got this person, I'm not going to see him. They have Medicaid. We only take one every 6 months. And they love having their name on the placard that they take Medicaid. Same with all the urgent cares. I'm out there all the time. I go to the ERs at the hospitals. I visit the neonatal teams. I want them to think of us. And the typical thing I get with a patient who's gotten out of Littleton Hospital is, we're number 20 on the list. And they're like, oh my God, you do take Medicaid? And we're like, yeah, because the first 19 don't, or they take one a year. So these poor people call and call and call, and they start out defeated. So, which is really frustrating. And so I try to tell anybody I can talk to in the community about that. And, be sure what you're referring them for. Just those little efforts you make. You save somebody, and they're not going to the hospital to see a stranger for care anymore. So, and they feel like they have somebody there for them. So, and to us, yes, we're helping Medicaid. We are highly dependent on hospitals for funding, and they used to give us money for free, and just now it's like, how many people are you keeping out of my hospital? Well, thank God for SDAC, even though it's a small percent of our patients. I can prove it now. So, it's helpful, and my boss is happy with that part. But we really feel if you don't partner and navigate with your patient and your community now, you will be paying for it later. And you can't depend on MDs and PAs and MPs to solve this problem. It's got to be company-wide and community-wide.
We currently have about 45,000 patients, and we are opening 4 clinics here in the next 6.
Lots.
Yeah, in the next couple of months. One specific to the refugee population that will be opening soon in Aurora. So ER is definitely something that we looked at prior to accountable care, and we continue to examine closely. And one thing that we've done a lot of is embedding ourselves in the hospitals, going to the local hospitals on a regular basis, partnering, getting to know who the janitors are, who the front desk is, who are the MAs, who are wheeling the patients out after an admission, and really tightening those relationships. Through those efforts, we've been able to develop good relationships to get good ER notifications. And once we are notified, we really try to get in touch with the patient as soon as possible. We found quickly that even 72 hours later, they've kind of moved on. It's fine. I don't need to come in. And we've gotten to the point now where we're calling them and they're still at the hospital, or they're getting in their car, or they're picking up their med. And we're asking a series of questions. And initially, a lot of those questions were focused on yes and no answers. And it's very easy when someone asks you if you're taking your meds to say yes. So we now really get in depth with how. How are you taking your meds? How do you want to receive your care? How can we alter what we're doing to be more accommodating to you? And one thing we heard over and over again is, your hours don't work for me. I work a full day, and when I need to get my child in, you're not open at 6 p.m. So we did move to having extended care at our North Aurora clinic. We will have that also at our Jefferson County Wheat Ridge Clinic. And that really has helped with some of those time frame issues. We also have hours open on Saturday. So one thing we are asking patients after an ER visit is, did they try to access MCPN? Did they try to go to extended care? Did they try to go to urgent care? We do a lot of urgent care education. And then ultimately, was their decision then to go to the hospital? And what was the reason behind going? And we try to do a lot of education around appropriate versus inappropriate use. We do rely on SDAC quite a bit. We had a volunteer come in about 2 years ago that said, I love data. And we said, we love you. She likes to slice and dice. She'll spend half of her day in SDAC. She loves it. She thinks it's amazing. And she has helped us develop a very comprehensive algorithm for looking at some different categories and who is high in multiple categories. So even though you're a high ER utilizer, are you high in your PPE, your CRG? What other categories are you high in where we can really target the cost as well as the utilization? So that's been really helpful to kind of really focus in on the patients that fall into 5 or 6 categories as opposed to someone that might just fall into one. Another big thing for us is the partnership piece. We partnership very closely with all of the local mental health entities, and that's been very helpful because we don't always know if our patients are receiving services there. It's a little bit of a fragmented system where our electronic health records don't talk to one another. So someone might be receiving meds and therapy at Aurora Mental Health, and we might not be aware of that. So we've partnered very closely with them to try to offer integrated care. And I really want to turn it over to Erin to talk a little bit more about her work as a nurse practitioner with MCPN. She sees patients out in the field, which really has been a great model for us, for her to go into the home and actually see what's happening. So when we ask, how are you taking your meds, they'll show Erin, and she'll see them pill splitting and trying different things with their meds that might be driving them to the ER, as well as her rounds in the emergency room.
The very good fortune of working with MCPN, and part of my job is to do home visits in the field, and that's something that I'd been doing in complement with clinic visits as well, but I've recently transitioned into full-time home visits with the Bridges to Care. We received a grant from Rutgers University to provide intensive community-based services, so I'm affiliated exclusively with that portion right now, but I've been doing home visits for about 3.5 years, and it's a really rich context for assessment. You can see how many flights of stairs a patient has to go up. You can see, is their home in good repair? I should probably have been an entomologist at some point, just to see like what's the living condition like. We travel in pairs at least when we do our home visits. So I have the luxury of working with clinical care coordinators, behavioral health providers, health coaches, and we have a very generous time apportioned to us for each visit. So it's a very thorough assessment, and it's not possible to do that same thing in the clinic. So I am able to see pill bottles at home. Are they expired? How many different names are on those bottles? How many different dosages? Fortunately, we have access to read-only records at the University Hospital, and that's where the majority of our patients are going within our grant anyway. So I'm able to access the discharge notes immediately and also our MCPN records so that I can compare and contrast and do a medication reconciliation on site live. And if there are any adjustments that need to be made, I can prescribe. So that's really great too in terms of making sure folks have been discharged on an appropriate medication. That it's affordable to them. I live for the $4 formulary. I'm sure many of you do as well. So it's something that we really give a lot of credence to is, I can tell the cows come home about how to take your meds and why, but if it's not affordable, easy, manageable, tolerable, it's not going to make inroads. And I think just honestly, the duration that we're able to spend with our patients really builds trust with them too. They see that we are invested in what they're telling us. We're exploring a lot of different things that feed into their experience with the healthcare system, and that brings me a lot of joy personally too, as a professional, to be able to do that in my job. Related to the ER, I guess I'm sort of the face of MCPN within the University Hospital ER right now, and I've had to transition away from doing rounds daily to doing once a week because we got lots of patients that I need to see, which is great. So I'm there collaborating with providers on site in the ER. If we have an MCPN patient there, I can pop in and greet them and say hi and let them know, hey, we're watching out for you. If they don't meet our grant criteria, I can very easily communicate with their PCP through our electronic medical records and pull records immediately from the ER and have them print it right over at the clinic where their PCP is. So just trying to seal the transition for them and make sure that everybody knows, close the loop, make sure that the right people know about the ER, and just trying to promote warm handoffs too between providers. If I've been spending rounds in what's called the clinical decision unit at the university hospital, and it's sort of, what did I call it, limbo perhaps, trying to figure out, all right, do we need to admit this patient, or, you know, if I can perhaps assist with coordinating close enough follow-up after discharge, maybe that patient can be discharged sooner and then have close PCP follow-up within the next 24 to 48 hours. So in that regard, I think it offers an opportunity for providers to feel like, okay, we have a discharge plan, this is reasonable for the patient, and then I can give a personal touch to that between the patients and the providers. So it's been a lot of fun. It's a big learning curve, and I realize that not every provider has the opportunity to work in the field, so I feel very fortunate about that.
So Erin's had the opportunity to do that through our grant, but we do have other providers that will do home visits for some of our more high need patients, and that just happens to be accountable care patients. So we do have a model for those high need comprehensive patients where their clinical care coordinator will go out to do home visits as well as their provider. The clinical piece has been very important, but what we have learned is it's very much so about the community piece. And that's where we have partnered very closely with Together Colorado to really recognize what are the community drivers of utilization. We can do everything we can do within the clinic or even in a home visit, but what's happening in their community that's driving them to the hospital? So we've learned a lot from Together Colorado and received a lot of information, and our patients have been very forthright with sharing their healthcare stories with Together Colorado staff and leaders. So I want to turn it over to Eliana to give a little bit more information about Together Colorado.
Of a grassroots community organization like Together Colorado. And for those who don't know, Together Colorado is a statewide, multi-faith, multiracial community organization. We work in 60 congregations and schools from Pueblo all the way to Fort Collins, but the majority of our work is in Metro Denver. And we've been working on healthcare access in Aurora since 2006, 2007. And the reason that we believed that the Camden Community Engagement Model and what we're now calling Bridges to Care here in Aurora was a really vital thing to help bring to Aurora through our work with the PICO National Network is because we believe that clinical transformation and providers doing their jobs really well, like all of you are doing, is critical, and that without asking patients why they're using the emergency room and how they would like to receive their care and what good care means to them, we're actually never going to be able to stem the flow of high utilizers, because the social drivers of utilization will continue to exist. Like that, we won't really have gotten to the root of the problem. So we have a team of about 10 right now. It's growing, soon to be probably 14 volunteers who are doing one-on-one relational visits with the patients enrolled in Bridges to Care, really taking the time to get to know them, hear their healthcare story from the perspective of someone who's not a healthcare provider, who doesn't use technical jargon, who is perhaps a trusted member of a faith community that the patient identifies with. And so I wanted to sort of tell a short story about a woman who actually had the opportunity to meet last night. We're bringing patients together in sort of small circles to share their stories, get to know one another, and start to build patient leadership so that when it comes time to say, how do we want to invest in healthcare in Aurora? How do we want those resources that have been saved to be invested in ways that will make your health better, that folks are well equipped to be leaders in that process. And this woman spoke about how she was using the ER because she had a really hard time getting an appointment. She was in a patient, an established patient at MCPN, and between her work and her role as a caregiver for her sister, she had a hard time waiting on the phone every morning for an hour to get that appointment. And so to get her high blood pressure medication filled, she had to go to the ER every single month. And when we asked her, did you feel like you got good care at the ER? Did you feel like it was worth that several $100s? The answer was a resounding no, right? And she's really been transformed by the project and spoke so very highly of the work that the clinical care team has done, and also about how much she's talking to her friends, neighbors, family about the importance of having a relationship with a primary care doctor, having a medical home, right? Knowing somebody that you can go see. And so she's going to be somebody, I believe, who's going to be a leader in transforming the world outside of our healthcare institutions so that all of Aurora is healthier and in better and more healthy, balanced relationship with primary care providers.
For those of you that aren't aware of the Salud Family Health Centers, we are also a federally qualified health center. We've got a patient population of about 73,000, 9 clinics in northeastern Colorado. We're in regions 1, 2, 3, and 6, and about 85% of our roughly 27,000 Medicaid recipients are part of the ACC. So this is a pretty significant program in our organization. When we, as an organization, decided to create a response to the key performance indicator of emergency department utilization, as primary care providers, I think our first reaction was, well, we need to educate our patients, right? So we created an education campaign called Emergencies Happen, Know Where to Go. And for those of us that speak Spanish, cuando tenga una emergencia, entérese a dónde ir, right? And so, we thought this was a good idea and started developing, reasons why it's appropriate to go to the ER and not appropriate to go to the ER in an effort to get patients into our clinics, right, and reduce ER rates. So while we were working on this project, I found myself driving like I do on most weeks, and I was on Colfax, right? We all know Colfax, and an RTD bus pulled up next to me, and there's this really nice glossy advertisement that was right there next to my vehicle, and it said, right next to a picture of this nice-looking guy on a mountain bike, "Accidents happen. Tell them, take me to undisclosed Major Denver Hospital." And I was thinking to myself, well, here we are saying emergencies happen, nowhere to go, but the RTD bus and that Major Denver Hospital says, no, take them to the ER, right? And so time went on, and I found myself driving down Colorado Boulevard, driving once again, and I saw one of those digital billboards, right, the ones that change, and I saw the sign that said, Major Denver Hospital ER wait time 15 minutes. I'm thinking to myself, man, it takes us 15 minutes to verify Medicaid sometimes. So I went to this undisclosed Major Denver Hospital's website, and I noticed that not only was that location listed on their website and the ER wait time, but every single location was listed. And if I wanted to, I could download an app for my smartphone, right, that would pinpoint my location and tell me this is where you should go based on all of our wait times. And then another occasion, I was at a meeting at a undisclosed Major Denver Hospital, and I drove by the emergency department, and I noticed there was a sign out front. You know what that sign said? Valet parking. And so here we are trying to educate our patients on how to make objective decisions on where to go when emergencies happen. But what they're hearing on the streets is go to the ER when an emergency happens. It's going to cost you about 0 to 30 minutes to wait. We'll take care of you and we'll park your car. And so for me, that was kind of a paradigm shift, and I'm thinking, well, maybe we need to rethink this. Last year, the Colorado Trust released a report entitled An Examination of Emergency Department Use in Colorado. I've got some copies of this here. They examined a sample of 10,000 Coloradans. and asked a detailed set of questions about emergency department utilization. You know who the highest utilizers of the emergency departments in Colorado is? Medicaid. Almost half of the individuals in this study reporting greater than or equal to 1 visit to the emergency department said that they did that because it was for a condition that could have been treated by a regular doctor if a regular doctor would have been available. And of that group, the top reason for visiting the emergency department was because they needed an appointment after regular business hours. And the second most common reason was the inability to secure a doctor's appointment as soon as it was needed. And so this data tells me that people in Denver, at least, and actually in the state of Colorado, aren't necessarily using the ER because they don't know where to go, right, when emergencies happening or happen. They're doing it because they wanted an appointment right away. And so with this data in mind, Salud wanted to determine if our education campaign was really the most effective way to reduce emergency department utilization, or if maybe we needed to do something else, right, to make sure that our system was promoting access. So we completed some studies of our own. At 2 major hospitals in 2 of our communities, we completed an emergency department utilization study. And we asked over 500 patients that had used these 2 major hospitals the reason that they went to the emergency department. In an effort to really find out, is this something that we could have taken care of? Is this something that you should have gone to the emergency department for, or is there this big gray area in between, right? And we discovered some really interesting trends. We discovered that there is a real parallel with the Colorado Trust study and the data that we gathered. We discovered that a lot of our patients went to the emergency department because our clinic wasn't open 2 in the morning, right? We're not open at 2 in the morning, so of course they're going to go to the ER. But we also discovered that a lot of patients historically were having difficulty getting an appointment at our clinics on a same-day basis, or they actually couldn't get an appointment, so they just decided, you know what, we're going to the ER. So we also looked at access, right? We wanted to know, okay, now we know more or less why patients are going to the ER. So how hard is it really to get an appointment at our clinic? The way you get an appointment at Salud is you call a phone number and a call center agent answers that phone. If you want an appointment, they schedule you the appointment. If you want an appointment on the same day, then they schedule the appointment if it's available. But if it's not available, they transfer you to the site to be triaged by our medical team. And so we tracked each of those calls that was set over to the site. And we discovered a really interesting fact about that correlation between ER utilization and access. We discovered that the hospital that had 28% of patients who basically went to the emergency department because they said, you know what, I couldn't get an appointment at the clinic, 28% of those patients was also our poorest performing clinic in that same community of people that said, you know what, I can't get access. So there's a direct correlation between ER utilization and actual access to our local Salud clinic. So, you know, I really believe that we live in a culture of immediate gratification. Anymore, this is the expectation, but not the exception, right? And I think this expectation directly relates to healthcare access. So consider right now a real example, right? So the mother of the 3-year-old Medicaid recipient who has a fever, won't stop crying, and it's 8 o'clock on a weeknight, right? Mom knows what she should do when an emergency happens. Mom knows that this fever really isn't necessarily something she has to go to the emergency department for, but what she wants is immediate gratification. She wants to know basically that her kid's going to be okay. So she chooses to go to the emergency department instead of come to her Salud clinic. So I really believe that as primary care medical providers, we need to be committed, as some have already mentioned, to being healthcare homes or patient-centered medical homes for our patients. So with that in mind, of course, let's think about NCQA, right, and their definition of what a patient-centered medical home is. Okay, patient-centered medical homes assure that patients can get the indicated care when and where they need it and want it. So hospital emergency departments are open 24 hours a day, 7 days a week, 365 days a year. If you have an issue, you can go to the emergency department. They'll take care of you, right? Wait times maybe 0 to 30 minutes. They'll park your car. They'll give you immediate gratification, and they'll reassure you that things are going to be okay. And so my challenge to us, and I think what we've really learned along the way, is that as primary care medical providers and patient-centered medical homes, we have to look for ways to ensure that our patients are receiving the care when and where they need it and want it. Because if we don't do that, then we know the data tells us, right? The data tells us that if they have Medicaid, they're going to seek that care somewhere else. And so as the winner of the least amount of takeaways, I'll read my takeaways right now in closing. Patient education may not be the single answer for reduction of inappropriate ED utilization. Understanding why our patients seek care at the ED will help us create effective and appropriate delivery systems of primary health care. And access to health care when and where a patient needs it is an essential component of this PCMH, and a lack of access may be directly correlated with inappropriate ED utilization.